Hello and welcome to ECGs for Students. My name is Dr. Sebastian Gracias, and as a follow-up to our previous segment, today we'll be discussing the electrical conduction system of the heart, conduction blocks, myocardial infarction, and tachyarrhythmias. Let's get started. The PQRST as seen in lead 2 corresponds to various events in the cardiac cycle: the P wave to atrial depolarization, the large QRS to ventricular depolarization, and the broad positive T wave to ventricular repolarization. The atria also repolarize simultaneously with the QRS, but are drowned out by the large size of the QRS owing to the large size of the ventricles in comparison with the atria. It's also important to measure the PR interval, which is the start of the P wave to the start of the Q wave, which should be between 3 to 5 small boxes, the length of the QRS, which should be less than 3 boxes, and the length of the start of the Q wave to the end of the T wave, the QT interval, which should be less than 440 milliseconds in men and less than 460 milliseconds in women, taking into account heart rate as well. Let's put the PQRST into context with electrical conduction. Starting at the SA node, the atria are depolarized by a web of conduction that spreads in all directions, which is largely absorbed by the fibromuscular sheath seen in black lines. We can summarize this with the P wave, and only impulses that head towards the AV node are conducted further to the ventricles after a 250 millisecond pause that allows the atria to completely contract. After this, electricity travels down the bundle of His and the bundle branches to give us the large QRS. Note that the P and QRS waves both travel towards lead 2 and are positive, but the QRS is bigger owing to the relative increased size of the ventricles in comparison to the atria. Don't forget about our little ghost wave that represents atrial repolarization, and we finish off with the T wave. This travels opposite to lead 2 and is opposite in terms of current to depolarization as its repolarization. The opposite of an opposite can be compared to the negative of a negative, which is a positive deflection in the ECG for the same reason. This is a normal ECG for you to calculate the PR, QT, and QRS lengths at the end of this session to ensure you know how to do so. Now, we've looked at the PQRST and certain parameters and their normal ranges. It's time to understand the implications of deranged values for these measurements. A prolonged PR interval can indicate a heart block, while a long QRS can indicate ventricular ectopy, ventricular tachycardia if the rate is more than 100 beats per minute, or a bundle branch block. A prolonged QT interval can predispose an individual to the ventricular tachycardia known as torsade de pointe, which you will see shortly. In simple terms, heart block means a blockage of conduction from the atria to the ventricles at the level of the AV node in red. There are 3 types, and type 1 has a prolonged but fixed PR interval, which means it's more than 5 small boxes in length, greater than 200 milliseconds. In type 2 heart block, we see ventricular dropped beats, and there are 2 subcategories. In subcategory 1, there is progressive prolongation of the PR interval, and then a dropped beat at a certain ratio. For example, let's take a patient with 3:1 type 2 heart block. This would mean that for every 3 P waves, 1 QRS is not conducted, and these 3 P waves have a prolonged PR interval in a progressive fashion. For example, PR interval for the first wave could be 280 milliseconds, the PR interval for the second wave could be 300, and then 320, and then a dropped beat. The important thing to remember is that this ratio is consistent for a particular individual, i.e., after every 3 P waves, 1 P wave is not conducted to give a short QRS, or a narrow QRS. In contrast, type 2 heart block category 2 may have a normal or prolonged PR interval, but random dropped beats that cannot be predicted. And this is how I remember that it's type 2 category 2, as random drop beats can be thought of as being more severe than predictable dropped beats in type 2 category 1. Type 3 heart block is characterized by AV dissociation, which means the P waves occur at regular intervals to themselves, the QRSs occur at regular intervals to themselves, but there is no relationship between the P and QRS waves at all. The term specialized conduction reveals that the specialized conduction system of the heart consists of cells with many gap junctions and therefore low resistance to electricity. In contrast, the non-specialized cardiac myocytes can also conduct electricity, but have less gap junctions and do so more slowly. So if you see a broad QRS, i.e. a QRS of greater than 120 milliseconds in length, that would mean that the specialized conduction system is not being used, and that conduction is being spread from non-specialized to non-specialized to non-specialized myocyte, and this may be consistent with certain pathologies. The first would be a bundle branch block. When we think about a QRS that is normal, it is in fact not a single wave, but two QRSs of the left and right ventricle superimposed, like so. The red is the left ventricle, and the right is the right ventricle, superimposing exactly so that we see only one QRS. In contrast, if we had a right bundle branch block, the left ventricle would depolarize first, and the right ventricle shortly afterwards slightly out of sync so that we see a break in the QRS. This is called an RSR wave. The first R from the positive deflection of the left ventricle, the S from the first negative deflection of the left ventricle, and the second R from the first positive deflection of the right ventricle. Now that we know that a bundle branch block is characterized by RSR, we need to know how to detect if it's left or right bundle branches that are actually blocked, and we do so by checking the axis. If you imagine a right bundle branch block, the left bundle branch will compensate by sending impulses towards the right ventricle, from left to right. This is in contrast to a normal axis, so we see a reversal of the axis in the chest leads, i.e. a positive deflection in V1 and a negative deflection in V6. If the left bundle branch is blocked, the right bundle branch compensates by sending impulses from right to left, which is in keeping with the normal axis. So we see negative deflections in V1, which is expected, and positive deflections in V6, which are also expected. So combining the RSR wave together with whether the axis is reversed or not gives us not only information about a bundle branch being present, but also which of the two bundle branches are involved. A useful acronym is William-Morrow. The two L's in William reminding you that the left bundle branch is involved with a W in V1 and an M in V6. The two R's in Morrow remind you that a right bundle branch block has an M in V1 and a W in V6. Tachycardias can be broken down into supraventricular and ventricular, and this often confuses students, but the principles behind it are core to understanding why these words are used. If the QRS is narrow, i.e. less than 3 boxes in length, we know that the specialized conduction system is being used, and it is likely that the impulses have their root in the sinoatrial node or the atrioventricular node, which are above the ventricle, i.e. supraventricular. If the QRS is broad, that means that the specialized conduction system is not being used, and the focus from which those QRSs are being generated is likely in the ventricles outside the specialized system, i.e. the tachycardia is ventricular. Now that we know what a VTach is, it's important to understand that they can be either monomorphic or polymorphic. Monomorphic means that each QRS looks the same to the one before and after, while polymorphic means that each and every QRS looks different to the one before and after. The most important polymorphic VT to be aware of is torsade de pointe, which is caused by a prolonged QT interval. If you're having trouble remembering what twisting of the points, which is torsade de pointe in French, looks like, remember the cover of the album of the Arctic Monkeys labeled AM. The AM album cover art looks exactly like what we would expect to see in torsade de pointe. Lastly, myocardial infarction can be broken down into STEMIs and non-STEMIs, i.e. ST elevated or non-ST elevated. In ST elevated MI, you have a complete blockage of the artery and an elevation of the ST segment, which is analogous to if someone was to immediately cut off your oxygen supply by trying to choke you from behind. The immediate cessation of oxygen supply would alarm you in the same way that the heart is alarmed and elevates its ST segment. Also remember that the complete blockage in ST segment will remind you that there's a complete death of all 3 layers of the heart supplied by that artery. Conversely, in non-ST segment elevation MI, not all 3 layers are involved and not the entire artery is blocked off. This is analogous to chronic ischemia in the same way that if someone was to chronically reduce the oxygen supply in a room over 10 years, you mightn't realize it and might actually have a gradual decrease in your consciousness. A depression in consciousness analogous to the ST depression or T-wave inversion of the heart. Lastly, in terms of tachycardias, we need to be aware of the supraventricular AFib and aflutter. AFib is caused by a shiver of the atria due to multiple ectopic foci firing impulses in all directions. This is why we neither see a discrete P wave nor a smooth isoelectric baseline. What we do see, however, is an irregularly irregular QRS pattern. This is caused because the multiple ectopic foci fire impulses in different directions in a different time, all of which is left up to chance. So the chances of an impulse being fired in the direction of the AVN at a time during which the AVN can accept it and send it onwards to the ventricles is completely left up to chance, reflected by the QRS's relationship with each other being completely left up to chance as well. Atrial flutter has a similar risk factor profile to atrial fibrillation, but a slightly different pathophysiology, the cause here being a re-entry circuit between the sinoatrial node and the atrioventricular node. In this case, the sinoatrial node fires at approximately 300 beats per minute, but the AV node acts as a traffic controller, reducing conduction rates in a 2:1 ratio, 3:1 ratio, etc., causing beats of 150 beats per minute and 100 beats per minute respectively. The ECG finding in atrial flutter is a sawtooth appearance, and we see what the ratio is of conduction by saying how many sawtooths occur before each QRS. 3 sawtooths, for example, before 1 QRS is a 3:1 conduction ratio. That concludes part 2 of ECGs for students. You can find our contact details for feedback or questions in the description below, and subscribe to our channel for further instructional videos on general medicine and general surgery. Thank you for watching, and we hope to see you soon.